I'm not sure if we're running on Berkeley time or not, but I will go on ahead and get started since it is 12 and I want to respect Dr. DiTomas' time. My name is Laila Sheira. I am on the Public Health Alumni Association board, and I'm pleased to be representing the board today and bringing you this webinar entitled Improving Care and Restoring Dignity for the U.S. Prison Population. Before I introduce the speaker and hand it off to her, I wanted to just also take advantage of you all here to say, if you want to learn more about the Alumni Health Association, you can look it up at this link, and also just, if you type in Berkeley Alumni Association into Google, you'll learn more. And then also we accept new members every year in the spring, and so if you're interested in learning more about what we do, and after learning more you want to be a part of it, you can also on that same webpage find the application. I just wanted to quickly promote two events that are either related to the work that we do or sponsored by the Public Health Alumni Association. The first one is a film screening and discussion tonight at Berkeley Way West regarding what happened to DeJuan Armstrong. This is promoted by the Berkeley Public Health DICE, so Diversity, Inclusion, Community, and Equity Committee, and the Ella Baker Center for Human Rights. So this will be an excellent event. Dinner is going to be served tonight at 5:30 to 7:30, and you can learn, there's a panelist as well as the filmmaker that will be there. And then lastly, before I introduce our speaker, the Public Health Alumni Association will be hosting a student and alumni networking mixer on Thursday, December 5th, 5:30 to 7:30. It's a good idea for you to register if you can see the link at the end, the short link at the end, so that they can have a good head count for the complimentary appetizers that will be served. So free food, if you can, we'd love to see you there. So going back to the speaker, Dr. DiTomas earned her MS and MD from the UC Berkeley UCSF Joint Medical Program, and she's board certified in family medicine and hospice and palliative medicine. She began her career in correctional medicine in 2006 as a consultant to the California Department of Corrections through the UCSF Correctional Medicine Consultation Network, where she was tasked with providing trainings and support for systems improvements. Now, as the hospice medical director, she works with her team to create an environment where her patients can live their final days with dignity, respect, and comfort. She's worked as a consultant through the Criminal Justice and Health Program at UCSF to train clinical and custodial staff on the special needs of older and seriously ill patients who are incarcerated. She served on the board of the Death Penalty Focus, which promotes the abolition of the death penalty from 2008 to 2014, and as an advisory board member to the UC Criminal Justice and Health Consortium. Since we can't give her a round of applause, just please join me in silently welcoming Dr. DiTomas.
Hi there, thank you so much. I'm going to share my screen. Okay. So I want to thank the Public Health Alumni Association for giving me this opportunity to share some of my experiences working with the Department of Corrections and Rehabilitation. I also want to mention that all of the opinions stated during this talk are mine and do not necessarily represent the views of California Department of Corrections or the Federal Receivership. So this is the California Medical Facility where I've worked for the last 13 years. It's one of 33 prisons in California that house approximately 120,000 people. I just wanted to talk a little bit about how I ended up in this place. I trained at UC Berkeley Joint Medical Program, the UC Berkeley UCSF Joint Medical Program. And then I did my residency at UCSF in the Family Medicine Department. And they train doctors to work with an urban underserved population. So I had a lot of experience working with patients at San Francisco General who struggled with mental illness, substance use disorder, intermittent incarceration, a lot of socioeconomic struggles. And a couple years after I completed my residency, there was a group of inmates who sued the state of California for providing a constitutionally unacceptably poor level of medical care. The judge gave the Department of Corrections 2 years to try to remedy the situation. And when they returned to court 2 years later, it was found that the Department of Corrections had not managed to improve the medical care. And so Judge Thelton Henderson put the Department of Corrections under a federal receivership, where we've been for the last approximately 15 years. So at that time, a large grant was given to UCSF, and they started the Correctional Medicine Consultation Network, and I was hired as a consultant to go into the prison system and help improve primary care trainings and doing chart reviews. And I was assigned to the California Medical Facility. Once I got there, I was very compelled by the work there. We have a hospice. We have a 17-bed inpatient hospice that I run for the state. That's a very compelling place. And the chief medical executive, Dr. Joseph Bick, had arrived at this facility in the early 90s after completing an infectious disease fellowship, because he saw that nobody was being treated with HIV in an appropriate manner at that time. So he came in. And so anyway, I've been there ever since, and I want to share with you a little bit about my experiences there. This was one of my hospice patients who died in our hospice. Under the lawsuit, it's called Plata versus the state of California. Whoops. There was a lot of improvements in medical care. In fact, it's completely transformed. All the physicians are now board certified in internal medicine or family medicine. The patients have primary care teams. They know who their doctor is, who their nurse is. They know how to access care. They have continuity of care. We have quality management tools, just like Kaiser, where we're able to track our diabetics and look for quality improvements. But even with the improved medical care, we still have a system of punishment in the country that incarcerates huge numbers of people for a very long time. We offer many too few opportunities for growth and rehabilitation while people are incarcerated. And then we do very little to help individuals reintegrate into society when they're released. So this is looking at the number of people incarcerated per 100,000. So the United States incarcerates more people than any other country in the world. Over 11 million people cycle through jails and prisons in the United States each year. In California, we have about 581 people per 100,000 that are incarcerated. This wasn't always the case. In the late 70s, early 80s, this phenomenon began with tough on crime laws, crackdowns on an increase in drug laws. And so it looks, you can tell from the graph that it peaked around 2008, and we've had some gentle decline in the numbers between around 2008 and currently. So obviously, having this many people incarcerated is harmful on many, many levels. And one of the levels is financial. It's not sustainable financially. This practice has cost over $80 billion a year. Monies which could be used to preventing crime, to treating people with mental illness, to treating people with substance use disorder. So the reasons for these changes, I'll just run through quickly. Many of you are probably aware of many of them. We have very long sentences in the United States compared to other countries. We have much stricter drug laws. We have the 3 strikes laws, where many people were incarcerated for nonviolent third strikes for life sentences. There's been some reform on that front. There's limits on judicial discretion. So even when a sentence doesn't make sense, it's usually the prosecuting attorneys that have the decision and not the judge. There's mandatory minimums, high recidivism rates, little or no reentry support, lack of community support for the mentally ill, and lack of treatment for substance use disorder. So all of this leads to more and more people. The 2008 Pew report is sort of the classic report. The numbers haven't changed significantly since 2008. And they reported 1 in 100 Americans are currently incarcerated. That's 1 in 30 men between the ages of 20 and 34. And if you look at Black men between the ages of 20 and 34, that's 1 in 9 currently incarcerated. The lifetime risk for an African American is 1 in 3 for having a period of incarceration. So every day I go to work, and there's some internal conflict between hoping that what I'm doing is making my patients healthier, so that then when they go back to society, they have a greater chance of being successful. But it's also challenging to be a part of a system that enforces policies that are clearly harmful to my patient's health. So I just want to bring forward some ideas of human rights issues that continue within our criminal justice system. There's many more than are what on this list, but I'm just going to bring up a few for the sake of time. So first, we'll talk a little bit about unjust sentencing laws. In many countries throughout Europe, the maximum sentence that people can be sentenced to is 15 years. Here in the United States, 1 in 10 people receive a life sentence. Sometimes their sentences such as 7 to life or 15 to life or 30 to life. These are called indeterminate sentences. And what it means is you don't really know how long you're going to serve. After you serve, say, you get a sentence of 7 to life. After 7 years, you can be considered by the parole board for release. But the majority of people are denied. And even if they're approved by the parole board, they have to go to the governor for final approval. So many people are not able to make it, even if they're approved by the parole board. This represents one of my patients. I'll call him Mr. B. He grew up in Detroit in the 1920s in the slums. And as a child, he had a chaotic and sometimes violent home life. He had a young Jewish friend whose family sort of took him in. They let him come over. They'd help him with homework. They'd feed him. They made him feel valuable. But when he got to be about 14, the other people in the apartment building said that this Jewish family couldn't allow a Black man in their apartment building or they would be evicted. And so my patient decided, rather than risking harming the family that he cared about, he went out to the streets. Within a year, he was addicted to heroin. He was stealing to support his habit. But later, he was able to overcome his addiction. He got married to the love of his life. They had 6 children, and he was a good husband and father until his addiction came back out in his 50s. He was involved in a drug deal. It went bad. There was an altercation, and the drug dealer was killed. He was sentenced to 7 to life for second-degree murder. And he always thought that if he just served his time and followed the rules, he would get out of prison in time to spend time with his wife and children again. He was a model prisoner for 39 years with only 1 write-up for smoking a cigarette right after they became banned. And then he died in our hospice at the age of 90. He never got over the guilt of not being able to be with his wife of 60 years when she died. And I don't think anyone intended for this man to die in prison, but it's the result of the system. It's a consequence of our current system. The next issue I want to think about a little is the impact of these sentences and our process of incarceration on the family and community. So in the United States, about 2.3 million children have an incarcerated parent. That's 1 in 14 US children experience at some point in their childhood having an incarcerated parent. In some states that have much higher incarcerations, as high as 1,000 per 100,000, such as Louisiana, West Virginia, it's 1 in 10 children will experience having an incarcerated parent during their childhood. So there's a huge cross-generational impact of this. Studies show that about half of male children who have an incarcerated parent will also be incarcerated. There's a huge financial challenge to staying connected with families. One of the things we know reduces recidivism is allowing people to stay connected with their friends and family while they're incarcerated. Other things are being older and having received more education while you spent time on the inside. So the cost to families, it's simple things like phone calls. There's only 1 phone service that prisoners are allowed to use in their families. So they charge rates sometimes as high as $1 or more a minute. And that can be very difficult for an older parent who may be on a fixed income to be able to talk to their children very often. There's costs for travel time. If the grandparents or the foster family taking care of the children want to bring them for a visit, California is a big state. It can involve a lot of travel costs, time away from jobs, missed work, and the inability to care for all of their other responsibilities. And then, of course, there's the impact of the loss of parental support, both emotionally and financially, for the children left behind. There's a book by Donald Brayman called Doing Time on the Outside that addresses a lot of the issues that the families of the incarcerated face. If you have an interest in that topic, it's a great book. The next topic I want to bring up is solitary confinement. So international law considers it a human rights violation to keep people in solitary confinement for more than 2 weeks. Solitary confinement is also called administrative segregation, restrictive housing, secure housing unit. These are all words that are used, but they basically mean solitary confinement, which is 22 to 23 hours a day in your cell alone without meaningful human interaction. Generally in California, people are allowed out 1 or 2 hours a day to exercise, sometimes to go to the law library in a very controlled environment. In California, there was a huge hunger strike, some of you might have heard of, in 2013, that was started by inmates at Pelican Bay Supermax prison who were in their secure housing unit. And it spread to over, well, I think it was almost 30,000 men who were on hunger strike in an effort to get the Department of Corrections to improve their processes around solitary confinement and reduce the numbers. And they did. There was a dramatic reduction in the number of people kept under these conditions. And many of them were there for gang affiliation. They hadn't actually done something wrong, but they were associated with a gang. And so they were kept there to prevent them from participating in any sort of gang function. So international law says that solitary confinement should only be used in exceptional cases for as short a period of time as possible and only as a last resort. Unfortunately, California still confines people for long-term solitary confinement when other options could certainly be available. When I was first working for the department, I had a patient who was a young man. He'd suffered a gunshot wound to the spine in his teen years, and he was paralyzed from the waist down. He had kind of a sporty wheelchair and wheeled himself around the institutional easily. He had a friendly disposition. He had suffered from some serious depression in the past, but while I knew him, he was doing very well. He got caught with a bag of marijuana and a cell phone in his cell. He was then put into solitary confinement for these rules violations, where he stayed for weeks, and then he was there for months while the administrators were trying to make a decision about what to do with him. Over the 6 months that he spent there, he slowly decompensated. He would come into my office. I could see that he was getting more and more depressed. His appearance became unkempt. He had a meticulously cared for goatee before, and it became fuzzy. He would have lint in his hair and his beard. He started to get anxious. He started asking me for pain medication all the time. I brought up my concerns with administration, but honestly, I was new at the time, and I, looking back, wish I had done more for him. He eventually ended up getting transferred to a mental health facility. And I wondered what had happened to him. And then a couple of years later, I was walking down the hallway, and he came zipping down the hallway in his wheelchair, looking back to his normal self. He had gained 40 pounds in solitary, and he was back down to an appropriate weight. He had a big smile on his face, and he came up to me and thanked me for what I had done for him. When honestly, I feel like what I did for him was fully inadequate. So overall, there's, if it's only done as a last resort and for the most extreme cases, I'm not sure that a cell phone and a bag of marijuana is something that leads to such danger that we have to isolate this man for 6 months and cause him to decompensate completely from a mental health perspective. There's clear evidence that those we keep in long-term solitary confinement are more likely to reoffend. Solitary confinement is responsible for half of all suicides in corrections. People in solitary do more self-harm. There's undeniable psychological damage. We are not making people more likely to not commit problems. We are making people more likely to be released and then have future victims. So the fourth issue I want to address is the incarceration of the mentally ill and cognitively impaired. One of the things that surprised me when I started working in the prison system was the number of people with serious mental illness who are incarcerated. I always thought that if you committed your crime when you were floridly psychotic, that you would be put into some sort of mental treatment facility, not prison, but that's absolutely not the case. Many, many patients have serious mental illness and are incarcerated, and their mental illness played a role in their crime. So there's about 700,000 people with severe mental illness admitted to US jails and prisons each year. New York City, Cook County, and LA County jails are the largest inpatient psychiatric units in the country. LA County Jail treats more mentally ill patients than all of the mental health treatment in that county put together. In the last 20, 30 years, California has doubled its mentally ill incarcerated persons. About 45–50% of people incarcerated in California have serious mental illness or have been treated for serious mental illness in the last year. Just like there's the lawsuit to improve medical care, Plata versus the governor, there was a lawsuit to improve mental health care, and that's Coleman versus the governor. But it doesn't matter how much we litigate and how much money we put at improving mental health inside of prisons, it's never going to be adequately successful. Prison is not an appropriate place to care for their mentally ill, period. The conditions are generally the opposite of how you would want to improve mental health. There's no privacy, there's lots of anxiety, lots of fear, a lot of boredom, loss of control, isolation from family, almost no privacy where you can go to feel safe. Prison should not be an acceptable way to treat the mentally ill, especially when there's alternatives that we know that work. So for example, many states have started mental health courts, including San Francisco County. In Michigan, there's one well-studied program that showed that for every dollar spent on using mental health courts to redirect people from incarceration to mental health treatment, every $1 spent saved $7, and recidivism, meaning future victims, recidivism rates were 300% less. So we have processes and systems and programs that we know work. We just need the political will to take the step to start implementing them. One other thought on this, we think of mental illness as something that would mitigate your sentence. I was mentally ill at the time I committed my crime. We would think people would get a lesser sentence, but there's studies that show that people with mental illness receive 30% longer sentences than their non-mental health counterparts for the same crimes. There's also studies looking at Proposition 36, which allowed for resentencing under the 3 strikes law, meaning that your 3rd strike actually had to be something violent or significant. You couldn't be incarcerated for life because you stole mascara or CDs from Kmart. But it shows that people with mental illness are 3 times less likely to be approved for reconsideration of sentence under Prop 36. Cognitively impaired inmates, also something I didn't realize before I worked in the system. And there was another lawsuit to help protect this population. It was Clark versus the governor of California. So these are people who have significant cognitive impairment. They are designated now because of Clark as DD1, DD2, or DD3. And this is your degree of cognitive impairment. So prior to Clark, people with developmental problems and cognitive impairment might sometimes sit in their cell and not go anywhere. They might never brush their teeth. They might not shower. And there was really no support system to help guide them and encourage them. There wasn't also a support system to prevent them from being victimized. Because of Clark, now the officers are required to prompt individuals who are identified through the Clark system to check them to prevent victimization and to prompt them regularly to take care of their activities of daily living, go to programming, go to their doctors. These individuals tend to have more frequent rules violations, and this in fact ends up having more time added to their sentences. When they're released, they're less likely to be able to follow through with discharge planning, and they're more likely to be reincarcerated. One of the patients that had been at the California Medical Facility for about 27 years, he had multiple chronic medical problems. He was in his 60s when he was going to be released. He suffered from diabetes, hypertension, hepatitis, coronary artery disease. He had mental health issues with serious depression. And he had mild cognitive impairment because of head trauma from child abuse. After 27 years of incarceration, he was going to be released, and I was asked to write his parole meds. He had 12 different medications, some psychiatric, some medically based. And when I saw him, I thought, there's no way this man is going to be able to transition to the community with almost no support. There's no way he's going to be able to remember to take his medicines, which, you know, a nurse has been handing him for the last 27 years. When I realized he was paroled to San Francisco County, I was happy because I had a friend who ran a transitions clinic. So I called her clinic. I got him a case manager. I made him a bus map of how to get from his single room occupancy hotel in the Tenderloin to the clinic. And I thought, okay, this guy, he's going to be okay. He's going to have support. When I called the case manager at the clinic a couple days later to see if they had connected, they had not. The case manager had reached out to the parole officer, but they weren't able to find my patient. About 2 weeks later, I got a letter from my patient saying, "Dear Dr. DiTomas, I am all alone. I have no one to help me. Can I please come back to prison?" I think that we could all do better in terms of reentry, not just for patients like this, but for all of our patients. So I've brought up a few issues that I see happen regularly at my job. There's also conditions of confinement, lack of substance use treatment, lack of reentry services, the death penalty, racial disparity in both sentencing and the death penalty. And all of these things together lead to a loss of dignity for those that we incarcerate. So now I want to move to a more positive topic. I want to talk first about a way in the California Department of Corrections, and there are positive things going on within the Department of Corrections and Rehabilitation. And one of those positive things is the hospice at the California Medical Facility. We allow patients to, who can't get compassionate release and can't go home with their families, to be allowed to die with dignity. We have a 17-bed inpatient hospice. It was started in the late 80s during the HIV epidemic. And then over the years, because of, we have an aging prison population, in the last 15 years, I've had 2 people die with HIV and only one of them died from HIV. So the vast majority of people that are sent to our hospice now are older and some younger people, but people dying of cancer and occasionally end organ failure, heart failure, renal failure. So the hospice was founded in response to the HIV epidemic. It was the first licensed hospice in a state prison setting. And as I mentioned, it's been the number of HIV patients. In 1995, there were 56 HIV-related deaths. And in 2018 and 2019 as well, there were none. In our hospice, we have the same criteria as in the community. A patient has to have a prognosis of less than 6 months, and they have to want comfort care only. If an individual in the Department of Corrections wishes to have chemotherapy and ongoing aggressive treatment, they have that option. But if they get to the point where they realize that the treatment is causing more harm than good, and they wish to be kept comfortable, that's when they would be able to come to the hospice. We have an interdisciplinary team model, so we have doctors who are boarded in hospice and palliative medicine. We have nurses with special training from UC Davis. We have a chaplain. We have a mental health clinician. We have a dietitian. We have an incredible inmate caregiver program where other inmates are trained to provide support to men as they're dying. And then one of the main things we do, the compassionate release laws state that if somebody has less than 6-month prognosis, they can be considered for compassionate release. So unless a patient absolutely does not want us to do this, we put every patient up for compassionate release. The problem is that the process takes 4 to 5 months, and you can't even apply for it until they have less than 6 months. So most people don't live long enough to get to that point. This is just a picture of our hospice. It looks more like a nursing home than a hospice. So it's a much more pleasant place for family to be able to visit. This is one of the rooms. You can see that most prison cells have the stainless steel toilets and sinks. This has porcelain. It doesn't seem like a big deal, but it definitely feels like a different place when you come into hospice. There's bars on the window, but we have the shutters, which also gives it a more homey feel. And then there's a group of women from the church in Vacaville who've made quilts for all the beds. This is our garden. We were actually funded by the California Healthcare Foundation, and we're able to build this beautiful garden. And this is when it was first taken. We actually have a lot more plants and things now. I need a new picture. But when families visit and they're able to sit out under the gazebo in the swing, we've actually had people get married here. It's a much nicer place for men to spend time with their children or grandchildren. One of the main goals of hospice and of our chaplain is to support all spiritual beliefs. This was one of our Buddhist patients, and the chaplain will bring in religious practitioners or spiritual practitioners from all over the area to allow support for people, whatever their beliefs may be. We had one patient who was a young Vietnamese man who died in the hospice years ago, and his mother had been visiting, and she was horrified because her belief system was that his soul would remain where his body died for eternity unless a particular ceremony was carried out. So our chaplain got approval from custody for her to come in with a candle and a flower and a cookie and perform the ceremony in the room where he died so that his spirit could be released from prison. So it's not just for the patients, it's also an incredibly supportive environment for the families. This was one of our Native American patients who really wanted to have contact with the earth in his final months. We have a lot of art programs and other recreational programs that can, provide diversion so you're not just thinking about your situation. There's good studies that when people are kept active as they are able, they're able to experience symptoms of nausea, pain, anxiety. Those symptoms diminish. We have an elaborate library of books on tape, and the chaplain has a large number of spiritual tapes. This is one of our patients and his daughter visiting. The chaplain, many of these men, their crimes may have involved their families. They often were, absorbed in substance use prior to incarceration. They may have been homeless. Many lost touch with their families years ago or didn't want to be a burden on their family and self-separated. But at the end of life, they often want to have reconciliation. They want to be able to say they're sorry. So a big part of what we do is track down families. Our chaplain is an expert at doing this. I remember one story where he was working, he had an address, but the family no longer lived at this address. So he used Google Street View and he went to the house. He spun the camera around and there was a church across the street. So he zoomed in on the sign and then called that church. And the people at the church knew the family that had lived across the street and they knew where they had moved to. So they were able to provide contact information. And that man and his family were able to connect before he died. So we have lots of stories like that. We also have a story of our patient was actually very, very violent in his youth. He was a raging alcoholic, and at one night in a violent rage, he killed his wife when he was drunk in front of his 3 young children, 3 girls. So when he came to hospice, he wanted to say he was sorry for what he had done and how he had, ruined their lives. And the chaplain contacted them and they initially said they want nothing to do with him, that he was a monster. But a few days later, they called back and said, actually we do want to see him before he dies. And we arranged for them to come in. And in a supportive environment, they were able to talk. They ended up speaking for several hours. He was able to ask forgiveness, and they were able to give it to him. So he died with that closure. These three women were in their 30s at this time, and they were able to live the rest of their lives without having the idea of this monster as their father. So it's a very open visiting policy. We allow children in, even if somebody has a history of a felony. When the patient's really at the end of life, custody will often make an exception and allow a family member to come in. I'm probably going over time. Okay. So I want to mention our inmate caregivers. This program is run by our chaplain. They have a strict selection criteria, but 65% of our caregivers have a life sentence. Now, some of these are the indeterminate sentences where they have 15 to life or 30 to life. So they have a chance of parole. But we have, these are men who have done significant crimes and want to give back something because they are in a very different place in their life now. They get extensive training in end-of-life care. We actually had a team from the New York Times Magazine come and spend 2 weeks with us. And they ended up writing a really lovely article in the Sunday magazine from May of 2018 about 3 of our young inmate caregivers. So these are men who did something very violent. Usually, I believe several were gang-related crimes when they were 17, 18, 19. And now they're in their 30s. They've spent more than half their life in prison. And they're working within the hospice as a way to give back. This is Kevon Lyman, one of our caregivers, and he's helping one of our patients. He said, before, I was numb. Death didn't hold the weight it should have. This program is great on many levels. So our patients they're dying in prison. As compassionate as a medical staff may be, that's not our lived situation. And so the inmate caregivers are able to come at this with a perspective of understanding. They connect with these men very intensely. Often by the time they die, they consider them family. It's a powerful experience for the inmate workers. It gives meaning to their lives. There's not a lot of jobs in prison that are truly meaningful. It teaches empathy skills, self-worth. These men talk about how much more valuable their life feels now. And in addition, it provides assistance to staff. Inmate caregivers aren't allowed to provide any medical care independently, but they can assist nursing staff with transferring, with helping shower patients. And then they do things like play games and listen. They're trained by the chaplain to help people process their grief, help them reconnect with their families, help them with their symptoms, etc. So one of the things that helps me feel okay working within a system that I have a lot of internal conflict with is this idea of changing culture from the inside. It's important that we have people who advocate from the outside, and I try to do that through talking on programs such as this. But there's times when you do things on the inside and you see other people observing. So this is one of our officers. Officers have something like a 39% greater risk of suicide than the general working population. Job dissatisfaction is very common. It's very hard to work in an environment where you're taught that those you are tasked to care for are less than or other. And the hospice is, death is a great equalizer. So this is a place where everyone is willing to see the humanity of our patients. We had one patient who he wanted to speak with his daughter one last time before he died, but she was in a psychiatric isolation unit in a women's prison in Southern California. And we asked our warden to allow us to do this. And he said, well, we have to ask the other warden. And they allowed it to happen. She was brought together. They had a 15-minute phone call. And then her mental health team actually came together to give her grief support afterwards. But the best part for me was that I got an email from one of the correctional officers that was involved the next day. And he said in 25 years of service, this was the most rewarding thing that he had participated in. So I think having someone recognize that we can both allow people their humanity and provide safety and security is really important. So that's one small example within the California Department of Corrections. And I want to throw out another way, thinking more comprehensively and looking at the European model of prisons, specifically Norway. So in the 1990s, Norway was in crisis in their criminal justice system. They were actually very similar to us. They had 60 to 70% recidivism. So can you imagine, as a group of public health people, can you imagine a treatment that failed 60 to 70% of time, and we just kept giving it to our patients over and over and over again? That would never happen, but that's what we're doing in the correctional system. The Norway system was also plagued by drugs and violence. They had 2 staff members murdered in 1 year. And in 1997, they said, why do we keep doing what we know isn't working? We are not making society safer. We are making them less safe. So they implemented massive structural change. And now, 20 years later, their recidivism is 20%. So they have certain principles that they use now. There's this idea of progression. So everybody who comes into prison in Norway starts at the highest level, but they're quickly moved down to the lowest level of security that they need to keep people safe. So every day is a progression towards a goal. And every officer, in fact, every Norwegian citizen realizes that people who are incarcerated are going to be your neighbor one day, and we want them to get better. So they look at the punishment is your loss of liberty. But once you're inside the prison, their job is to make you a better neighbor. Part of how they do that is by normalization. When we put people in prison for 27 years and don't allow them to choose their own clothes or make their own food or actually make hardly any decisions, we are not making them likely to be successful once they're discharged. So normalization is where they try to keep things as much like the outside world as they can within prison. So that means letting the inmates wear their own clothes, calling them residents rather than inmates, allowing a lot of contact with their family. When people have progressed to a certain point, they allow them furlough. So they actually go off. So as they're getting close to their release time, they will be allowed out for the day to go work. So they can start building their skills and building their social and communication skills. There's also this third principle called dynamic security. So the way that we do incarceration in the United States is static security. We use handcuffs, we use restraints, we use alarms, we use control measures. And that's what Norway was doing. And what they changed was they completely redid the way that they trained their officers. So the officer training became a 2-year process where they learned the officers were not just guards anymore. They were trained to be coaches, mentors, motivators, conflict resolvers. They were taught motivational interviewing. They were taught psychology, human rights, ethics. They were given tools to use to de-escalate. They were made to feel that they were important professionals who were going to actually make society safer. So this is called dynamic security. Instead of putting people in chains, I actually develop an interpersonal relationship, an appropriate and professional interpersonal relationship. But by knowing the individuals in your pod, you're able to control the situation. And when we were in Norway, someone said, well, what do you do when there's a fight? And one of the officers said, there's almost never fights. We're part of this group. When there starts to be tension, we know about it long before it explodes, and we're able to de-escalate it. And then finally, the import model. So in Norway, they remind each other that the community owns this individual and they will be returning to the community. So they try to keep up. The minute they walk in, they're talking about a discharge plan. Where are you going to work? How are you going to control your substance use disorder? Where are you going to get mental health support? Who are you going to live with? What job are you going to have? They're teaching people how to fill out resumes, how to do an interview from the very beginning. In our system, we occasionally do these things, but they're usually at the end, if they happen at all. So this is one of the rooms, the cells, basically. Not all the prisons look this nice, because there's still some older prisons in Norway. But I guess the question is, you know, a penitentiary is a place where you go to think. It's a place where you think about how to be a better person. So the question is, do you want your neighbor to be the guy who spent the last 20 years thinking in this room? Or do you want him to be the guy who spent the last 20 years thinking in this room? I know I'd certainly prefer the first room. So this is a kitchenette. So the men are allowed to cook. You know, even people who are murderers are allowed to use the kitchen equipment. They usually work together. There's usually people who plan the meals specifically. Instead of being handed a meal, they're actually handed money. And they have little stores where they can go and buy their food. So they have to do meal planning. They have to do the cooking. Instead of being this hard wall between the officers and the men, they actually do recreation together to build relationships and learn to see each other as human beings. They have access to library resources, entertainment, so that they can feel good about themselves and have some positive experiences. There were comments from the Norwegian governors. Governor is another word for warden. We decided that talking tough, bad, and disrespectful does not make him a better person. And giving inmates responsibility is giving them training to be a good neighbor. We train prisoners to make decisions because that's what they'll have to do in society. So there's a program at UCSF called Amend that's worked with the prison law office previously and has taken a number of US states to Norway so that they can develop, they can learn from their processes. And obviously we can't take Norway and plop it on our systems, but there are tidbits and practices that we can take. One of the people on the New York, the delegate from North Dakota, said, as a judge, after his experience in Norway, said, as a judge, I have the power to take away a person's freedom. I have no right to take away their human dignity. For our benefit and security, we should remind those in prisons of their potential and human dignity. We also need to remind ourselves that they are part of the community. So in North Dakota, the director of corrections is an incredible woman named Leanne Birch. And she came back from her experience in Norway and said, you know, I knew what we were doing wasn't working, but I didn't know how to fix it. And within a couple months, she had made significant reform. So one of the things she did when she got back was she had every man who was in solitary confinement, they pulled their records and looked at why are they there, how long have they been there. There were over 100 men in solitary confinement. And within, I believe it was like 6 weeks, they had that number down to 6 with no increase in violence in their institution. Many of the people, she would go through the charts, and there were people, one of the reasons to go to solitary was having 15 rules violations. And there were men who had 15 rules violations of not tucking in their shirt. So it certainly wasn't being used as only when absolutely necessary. So that's been, that was years ago, maybe 5 or 6 years ago, and she's managed to keep the number around 10 and used for as short a time as possible. In addition, they started using a lot more carrots. The US criminal justice system has very few carrots, but they do things like if you have certain positive behaviors, they have picnics where the inmates' families and children can come. They have a picnic, they play softball. They've developed furlough programs, whereas people are nearing the end of their sentence, they're able to go out and work in the community and develop vocational skills before they leave. She's known as saying, public safety is not increased by inflicting pain, humiliation, violence, and disrespect. So the Amend program at UCSF is run by Dr. Bree Williams. She's a professor of geriatrics who's done a lot of work looking at the aging prison population. And as she was working, you know, in the prison setting, learning more about the aging prisoners, she also saw all of the problems that face the correctional officers. they work in a very unhealthy environment. So she's developed the Amend program that's taking different states. And if you are at all interested in this topic, they have a great video based on their most recent trip, which was taking Oregon. So the Oregon group went about 6 months ago, and they implemented some of these changes. At first, they were planning to implement some Norway type changes in a low risk unit, but after they were there, they realized that these processes are most important in our highest risk, most behaviorally complex patient populations. So they implemented it in a very challenging unit. They've done a follow-up study 6 months later. There's 54% less violence on the unit now, 27% less sick calls by officers. The officers talk about how they enjoy coming to work now, that they feel like they're making a difference, that they're actually helping somebody. And also very exciting is a delegate from California went to Norway in September, and they're planning to pilot some of these changes in 2 state prisons in California. So if any of you wish to get involved in criminal justice reform, I think this is a very exciting trend. So with that, I will open up to questions. I'm going to stop share. And then,
So there's 2 questions. There's the Q&A button at the bottom.
Okay.
You can see the first question. It says, this seems like a policy issue. How can we as public health professionals help make change at the local, state, and federal level? And anyone else who has questions, feel free to start typing them in.
Yes, it's a policy issue. Honestly, it's a public health issue. And I think the same way that we make policy changes on any topic, we've done, I was on a panel for the UC Criminal Justice and Health Consortium, and on the panel was Lonnie Hancock, and she was saying that all of these advocacy groups throw in policy briefs all the time. They write up a policy brief based on their wishes. And she said academics are so worried about having all the data and having everything, all the proof be in before they send in a policy brief, that they get behind the ball. So I would recommend, as you learn about these things, as you're doing research on some of the problems, don't wait until you have all of the research in. Go ahead and put together a policy brief. Start talking to your legislators sooner than later.
The next question is it clear that there is a significant issue related to incarceration rates? Is there any current policy work seeking to improve the statistics you presented earlier?
The pendulum is swinging. I mean, in the media, we hear about mass incarceration all the time at a completely different level than we did, say, 10, 15 years ago. Michael Romano is a lawyer from Stanford who started the 3 Strikes Project, and looking at reforming the 3 Strikes law, that led to Proposition 36, which California voters overwhelmingly supported. So I think there are moves towards rethinking how we do sentencing, rethinking how we do, prosecutorial discretion, and how we allow people to plea bargain. All of these issues play into the problem. There's a group called the Sentencing Project that spends a lot of time working on these issues, and that would be a resource if you're interested in getting involved in this resentencing work.
Great. Another question we have is, what has led to the doubling of incarcerated individuals with mental illness, and how can we reverse this trend?
I can't describe all of the many reasons. I think that most of it has to do with a loss of social support in the community with funding cuts. I know when I worked at San Francisco General Hospital, there were 5 or 6 different inpatient psychiatric units. And I believe that's been completely chopped. There's maybe 1 now, maybe 2. In the 80s, there was 70s and 80s, there was a big move to deinstitutionalize the mentally ill. And, that was pushed for by mental health advocates. But the idea was that we didn't need to keep these people in institutions. We should be providing them community resources so that they can live with their families. They can be functional members of society, but have support on the outside. But unfortunately, when that happened, Ronald Reagan vetoed the funding. So it was never funded that they would get increases in the support in the community, but they were deinstitutionalized. So that certainly doesn't account for all of the rise in the mentally ill in prison, but there's a direct correlation between loss of mental health resources in the community and increases in the prison.
Great, and we have a great question here. What is your perspective on the influence of for-profit incarceration facilities upon both recidivism and rejection of kinder, gentler correction?
I'm not an expert on for-profit prisons. I find them morally reprehensible. We shouldn't be making money off of this. Nobody should be making money off of this. And my understanding about the for-profit prisons is that they don't actually fall under the requirements that state prisons do in terms of auditing and monitoring. So they are able to get away with many things that a state prison wouldn't be able to get away with because of the auditing that occurs for us.
So is there, my follow-up on this question is there data on recidivism rates on a state incarceration facility compared to a private one?
I don't know of that research. It may exist. The federal system used a lot more private, well, I don't know. It varies state by state. So in California, we're actually under the Department of Corrections. There's one or two very small private facilities, but we don't use the private prison system. So I'm not as familiar with that. I know in the federal system, there's a lot of private prisons, and under Obama, they actually outlawed the use of private prison corporations. And as soon as Trump came into office, they reversed that. So I think there's many people who recognize the danger of making prison for profit.
And then one last question here. How were pregnant and parenting incarcerated people treated in Norway? Do they have access to newborns and supported with the continuation of lactation?
You know, I did not visit a female prison in Norway, so I can't really speak to that. I've read about things where programs where they do, and even in the United States, there are some state systems that allow women to keep their children, I think, up to the first year with them in an incarcerated setting. But obviously, as the child gets older, that's not in their best interest. But I don't know about Norway specifically on that question.
Great. Well, if we don't have any other questions, thank you so much. A recording of this webinar will be available in a few weeks once we are able to get it closed captioned. But thank you all for attending, and there's no other questions. Thank you so much, Dr. DiTomas.
Thank you.
Okay, I will close out the webinar now.